This is a case I'd like to present because I think it's interesting with the juxtaposition of the married couple and their retina findings and how I used it to change my clinical decision making and really educate patients on what is happening in their retina. This is me. I practice at 𝐲𝐚𝐚𝐿 Optometric Center. We've been using the RETeval device since July of 2022. Mainly we use it for diabetes, glaucoma. I do a lot of work in inherited retina disease, use it for that a lot, or just unexplained vision loss that doesn't have an anatomic or structural cause that we can find or that makes sense. So with the two patients, they're a long married couple. They came in for their routine comprehensive exams. No new vision complaints. They both have a history of diabetes, and they both were easily correctable to 20/20 with minimal change in their refractive error. We're going to start with the wife because she has a known history of diabetic retinopathy. So she is 72. She's insulin dependent and on a host of medications that go along with our triad of diabetes, high blood pressure, and high cholesterol. Her most recent A1C was 7.5, and that is about what she is within the last 6 to 18 months. It doesn't fluctuate too much, and it's higher than what it should be. She does have a history of cataract surgery in both eyes, and not only was it retinopathy that she had, but it was proliferative. She has a history of anti-VEGF injections in each eye because of macular edema, and she has an extensive amount of PRP that's in both eyes. Now that's been inactive, and she hasn't needed treatment in more than 5 years, and like I said, her vision's still 20/20 and very good, minimal complaints. But we ran an ERG for a couple of reasons. One, with how diseased and now damaged with the PRP her retina is, I'm expecting it to be abnormal. But two, because the PRP is physically damaging the peripheral retina, at some point it does affect the overall functioning of the retina, or it affects your overall ERG findings. So with this patient, I'm most curious of getting a baseline, matching that, making sure that there's no proliferative activity from a structural and anatomic standpoint. But then I'm going to use that as her baseline to then monitor her in the future to see if things are progressive or getting worse with that DR score. So she's seen every 6 months in the office because of this history and her abnormal ERG functioning. And with this, her DR score is high, it's 24.5. And just looking at the waveforms below, they're very shallow and they're spaced out too far. You know, it's a slower implicit time. It is not high enough amplitude, and you can easily show this to the patient and explain why it is abnormal and what the concerns are. So here's pictures of her retina. Like I said, extensive PRP. She still has 4 quadrants of dot and blot hemorrhages in both eyes. She has your AV narrowing, she has AV nicking, but there's no macular edema and there's no signs of active proliferative retinopathy. She does have a moderate epiretinal membrane in the right eye centrally more than the left eye, was more peripheral, and she has microaneurysms and early exudate that as you're going through the en face images you can start to pick up more so than just looking at the photo or even with a 90 alone, a little bit more detail with it. The OCTA shows signs of diabetic retinopathy and capillary damage where the foveal avascular zone is now irregular and it's not symmetric between each eye. And you can visibly see the capillary dropout that's happening in both eyes, a little bit more so in the right compared to the left eye, but both definitely abnormal. So we'll skip forward for a year because she's been stable. We've been doing the ERG each time she comes in, every 6 months. And so a year later, her DR score is 24.2. Previously it was 24.5. That's not a statistically significant change, so I consider her stable, and if anything it's in the right direction, and it's a lower DR score than it was previous. So still is classified as inactive proliferative diabetic retinopathy in each eye, and I think she's also stable from a functional standpoint, so I'm comfortable in the every 6 months monitoring period. So like I said, even though her DR score is high, I know that her risk of needing reintervention is also high, but it's remained stable for her, so it doesn't seem that functionally her disease is progressing. She's also still, again, easily correctable to 20/20. So I keep seeing her every 6 months, again, talk to her, and I always send a report to her primary care doctor about better control of her blood sugar, and the A1C is still higher than what a target should be, especially with her history of the retinopathy. So the ERG gave me another piece of data that I can watch her progression or potential for progression with a functional piece of data, as well as doing our standard, photography and OCTs and monitoring from the anatomic perspective. So although she's been anatomically stable, the fact that she's also functionally stable makes me feel comfortable that we're still making the right decisions and seeing her in the office more frequently. So this is then juxtaposed to her husband, who's 80. He has dementia, and that's the reason why they're seen in the same room, because the wife wants to make sure she can hear everything and understand what is happening with him, because he may not remember. His most current A1C was 7.4, and that's higher than normal for him. Usually he is under 7, and he's now even more concerned because his blood glucose is running higher in the last 6 weeks, because his Mounjaro is on back order with the pharmacy. So he hasn't even used it in the last 6 weeks, and that he was put on 6 months ago when his A1C was higher. He also has had cataract surgery in both eyes. He has a history of known small hard drusen, but no history of diabetic retinopathy. So here are the pictures of his posterior pole. Small drusen, again, very small, but there's no diabetic retinopathy seen, and this is stable from previous years when I've seen him. We ran an OCT. He does, again, have signs of the small drusen, mild epiretinal membrane that is not central in nature, so not causing any symptoms, and there's no signs of diabetic retinopathy or macular edema from the OCT-B scan. Now from the OCT-A, this is always more difficult for the technician to obtain because the patient really has to stay still. So it's not the most perfect test, but generalities you can still get is he absolutely has an abnormal and asymmetric foveolae vascular zone, and he absolutely has capillary dropout in both eyes. How accurate that is, it's hard to say. I would repeat it again and we'll watch it, but that's what we're picking up from this scan, different from the OCT, the en-pos, and the B scan. And then, of course, we ran the ERG because we talked about, I'm happy that you're seeing well, that there is no diabetic retinopathy that I can find, but even more importantly, to correlate that all together is that the function of your retina is excellent. So his DR score was 16, perfectly within normal. Again, drop down and look at the waveforms. They're easily within those statistical boxes, both with regards to amplitude or the height of those waveforms, as well as the implicit time or how much time there is between those waveforms, and very symmetric between each eye, which we like to see. So patient had concern because he was under-controlled with his diabetes. He knew that that was the case. Now he knew it was even higher, his sugars, because of the back order. And he's known what his wife has gone through with all of her treatments and need for so many follow-up care and the risk of vision loss that she has had and still has. So from his perspective, it was all good news. Reassured him that in the short term, retina function is excellent. There's no signs of diabetic retinopathy. Of course, as we both already knew, he needs better control of his blood sugar to maintain his healthy retina. So I, again, sent a letter to PCP. PCP is already aware of the issues and trying to figure it out with the patient. So hopefully the next time I see him, sugars will be down, A1C will be a little bit more normalized, and I'll repeat the ERG to see if it changes. So it was great talking with both of them. It was both a good news situation where, yes, the wife was abnormal, but she was stable and abnormal. And the husband, we were really able to get excellent data to reassure him that I do not think in the short term you will be diagnosed with any kind of diabetic retinopathy that will be visually threatening. So of course we'll get a better control, but we'll monitor this over time. I'm seeing them both back in 6 months to take another look, and we'll move forward from there. Thank you. Happy to take questions if there are any.